We have two special guests here this morning here in our studio with us. We're going to talk a little today about the neurologic complications of COVID-19. This is a pretty important topic, and here to address it is Colleen Lechtenberg, who's the director of our stroke program, and Gary Gronseth, who is the chair of neurology. Both are longtime folks here at KU, good friends and great docs. So we have I think this will be a really important program today. Hope we get a lot of good questions around that, especially because we know we're headed into Memorial Day weekend, and everybody wants to travel. Everybody wants to know, is it safe to go back into the water, Hawkeye? So lead us off. First of all, how are things going here, and what do you think about the safety of Memorial Day weekend?
So it's good, thank you. Yeah, this is, I think, been termed the Hawk's Nest by Logan, our technician. So, currently at the hospital, we have 15 patients. In the hospital, 7 of those in the ICU and 4 of those on the ventilator. So hopefully, as we get back out into public and people are gathering, hopefully not more than 10 and doing the social distancing, we won't see a surge or a spike in cases in 7 to 10 days.
Of information out there about the super spreader events. I think that's probably what we have to really be careful with. People wanting to get together, have hot dogs, beers, and pretty soon you violate the social distancing stuff. Pretty soon, a lot of hugs and handshakes, and pretty soon a lot of COVID, right? I mean, talk to us about super spreader events.
Yeah, that's absolutely true. We know that super spreading events are nothing new. We saw these with the original SARS. We saw this with MERS. These are events, and nobody can really predict who is a super spreader, when is a super spreading event going to occur, but we understand they occur. What are the biggest risk factors for super spreading events? It's obviously confined spaces, so smaller area. So certainly we've always been a proponent of doing outdoor things, but along with the confined spaces is the amount of people present in those spaces. Really lack of good airflow, because you certainly have better airflow if you're outdoors. And then again, time that you're with those people. And when you combine all of those and you have more people in a smaller space for a longer amount of time, that can certainly lead to a super spreading event.
Yeah, those are I think are big concerns for looking at, because what we don't want to see are all the complications from COVID-19 which can occur. And so Gary, talk to us a little bit about some of the things that are happening from a neurological disease standpoint, because clearly that's pretty devastating. Those things, those kind of complications can stick around forever.
So COVID-19 can cause a variety of neurologic complications. The one that we are in most fear of is stroke. So, and we see stroke in 2 settings. So patients that are very sick, that are in the ICU, they have a lot of inflammation, and inflammation leads to clotting, and that can cause strokes. Of course, they have clotting that affects a lot of other areas, but we're seeing those patients as well. But the other thing that's separate for that is in patients that are infected, and they seem to have a mild infection in that they're not particularly sick. They may not even know that they have COVID-19, and we're seeing strokes in those patients as well. And that's very scary, because it's sort of unexpected. Of course, oftentimes we can treat those very effectively acutely, but that's the big fear there. So there's 2 categories of patients that we're seeing with strokes: the very ill patients, and we kind of expect that. We don't like to see it, but we look out for that. And then also patients that otherwise are feeling well, and then they develop a stroke related to COVID-19.
And that's a tough thing. So my wife sometimes thinks I've had a stroke because I do some stupid stuff at the house. Gary, have I had COVID-19?
Most people that have strokes don't have them from COVID-19, and most patients with COVID-19 will not get strokes. But it is an important complication to be aware of.
It is. And Colleen, this is an area that you practice in specifically. Right. Have you seen some patients with COVID-19 who have had a stroke, and has your team had to take care of folks like that?
We have not seen a lot of patients with COVID-19 and stroke. I think kind of what we're seeing a little bit more that's concerning is that people are not coming into the hospital when they're having stroke symptoms. And so they're going on.
It's the fear of COVID-19.
It's the fear of COVID-19 and people not seeking medical help and going on to have a stroke.
So talk to us a little bit about what happens with that, and what does it mean to delay care with strokes?
What we have done is looked at our data for our Comprehensive Stroke Center, and we've noticed some kind of concerning trends. One is that compared to last year, we have less ischemic stroke patients in the hospital. Also concerning is patients with mild to moderate stroke are not seeking medical attention. That is worrisome because even if somebody has mild to moderate stroke, they still can have significant disability, and then they miss treatment options, acute treatment options like TPA or the clot buster medication. So we can't stand a chance to try and reverse those symptoms. There's also concern because we don't get the opportunity to assess the risk factors and try and prevent another stroke.
You know, when I grew up in medicine back in I don't want to say how far, but probably more recently than Gronza did.
Thank you, Steve.
Yeah, I'm here for it, Gary. So, but we did grow up in an era where there was just nothing to do. It's so different today because those early interventions make all the difference.
Right. Right. So there are two main interventions to try and reverse stroke symptoms, but they're both time dependent. So patients need to come to the hospital as soon as they have these symptoms. So one of them is a clot buster medication that can only be given within 4.5 hours of symptom onset. That is very, very effective for mild to moderate stroke. So that's the treatment that these patients that aren't coming to the hospital are missing. The second intervention is a thrombectomy, and that requires specialized physicians at a comprehensive stroke center. They mechanically retrieve the clot, and that's typically, or that's used for patients with larger strokes and patients that have a large vessel occlusion.
Yeah, so those are tough things, and I think I understand we had a young person here at KU who maybe not got here quite in time.
Right. We have seen patients, we have a lower percentage of patients coming to the hospital in less than 4.5 hours. This particular patient waited several days, I believe it was 2 days, to come to the hospital out of concern for catching COVID.
And that's really a true tragedy because hospitals are pretty darn safe. I mean, we've really worked hard to make sure that patients are safe when they get here and that families are protected. And so I think when people delay care because they're afraid of COVID, what they're really doing is they're endangering their own life and how they're going to be able to live for the rest of their life.
Right.
So what else can people do? What are some of the signs and symptoms people should be watching out for when they're at home that should be an early warning sign?
Well, for the general public, we're using the BFAST acronym. B is for balance, E is for eyes, any kind of loss of vision, double vision, F for face, any facial droop, A for arms, a drift of the arm, and then S for speech, any alteration in speech. So that's kind of the straightforward thing that people can remember. If you have any of these symptoms, you go to the hospital immediately for medical care.
So doing dumb things doesn't count?
No.
Okay, well, maybe I'm safer than I thought I was. All right, well, let's see if there are any questions around these topics from our media who are often with us in this program. So we'll start with that before we go to general questions. Not hearing any, so I know there are some out there, and I'm going to bet they're going to focus on Memorial Day weekend a little.
We have a lot of those. One of them is sort of related. Should the public wear eye protection and a mask?
So Dana, that's the question we've been hearing a little bit from time to time. We know the answer to the mask is yes. What about the question about eye protection? And remember that masks are as much to prevent secretions from us going to others, really more so for especially the cotton and the ones that were made at home and not our medical grade. So really it's to prevent us from spreading the disease to others more than for us to be prevented from getting it spread to us.
Yeah, we certainly know that the face masks, and again, we have to make the distinction of a surgical mask or an N95 mask versus what we recommend the public to wear, which is a cloth face mask or something of that nature, just as you said, to help prevent the spread to other people should you be asymptomatic or pre-symptomatic. The question, should you wear eye protection? That is very good. There's not a consensus with public health about wearing eye protection. We know that here at the health system, that is one of the main tenets of our PPE. We do encourage and we make our healthcare providers wear goggles or a face mask, and that is to protect anything from going into the mucous membranes of the eye. Again, for public health guidance, there is no consensus on that. I don't think it's a bad idea. Certainly people with glasses or sunglasses, that may help. We've always made the distinction as well, though. However, even in the hospital, glasses are not considered eye protection, but certainly they could possibly protect you a little bit. I don't see anything bad if you are able to wear or do have glasses or a face mask, wearing those in public, specific eye protection goggles. So that is something to consider. And again, it would be an overabundance of caution and certainly not have any harmful effects of doing that.
So really, Gronzeth and I are the cool guys because we wear glasses and we have some element of protection from that, is what you're telling me.
I'm cool without
You probably have a little bit of protection. Certainly out in public, that may be somewhat sufficient. We've seen the story on the news media outlets of the virologist who's treated patients with AIDS and treated patients with Ebola. He did catch COVID-19. His biggest thought about how he got it was maybe on an airplane, even though he was wearing a mask and not touching his face and doing everything correctly. He suspects he got it through his eyes, through the mucous membranes of the eyes. So that's certainly a consideration to do.
I know when I go into crowded things, I actually have some of those goggles you can get down at Home Depot or the hardware store or Lowe's or wherever. And I do wear those, and the same ones I wear in the hospital, actually. And wait a minute, you've got yours right here.
Right.
Let's show them. Show our folks.
I mean, they're easy to wear, and
you look cool.
like Dana says, there's no harm in wearing them.
Yeah.
So you're not going to hurt anything by doing it.
Everything helps. You don't want to have a stroke, and you don't want to have. Where are mine? Oh, wait a minute. Wait for it. Colleen, you don't have yours with you. All right, we got our eye protection. We are cool.
And Dr. Stites, I would like to add, too, that when we first started doing this, to all of our healthcare providers, whether it's the physicians, the nurses in the ER or on the front line, we always made that distinction that certainly we wanted people to wear the hospital-provided masks and N95 masks, but certainly if they were able to get large goggles like this or eye protection from their home or a hardware store, we always accepted that because, again, these are larger than just normal glasses, so they would provide, and they do provide, adequate protection.
They're definitely larger than normal glasses, and because I'm now going to take mine off because I'm going to say that I'm protected in this room. Okay, Jill, we have another question.
We have lots of questions, and we do have them coming in on stroke as well. But to follow up on the theme of flying, we have a lot of questions. Is it safer to fly?
Or safer to take a car? Dana, you and I
if I get the glasses, does that help me?
So Dana, you and I have talked a lot about car versus airplane. Let's see where our debate lands today. I say car because you can control your environment. You know who's in it. There's not as much recirculated air from the outside, from a bunch of passengers around you, and you can roll down the windows or open up the pop top or whatever you need to do. So I feel pretty comfortable in a car. Airplanes, I don't know who's around me. It's harder to control the environment. When I got to get up and go to the bathroom, a lot of people have been there, and I don't know if I have all the things to wipe it down. I mean, it just feels more contained, and we know that recirculated air is a bit of a problem, Dana.
Yeah, absolutely. I agree with you. The car is very controlled. Getting out to get gas or get drive-through if you're on a longer trip, you can control that. You can do hand hygiene in the car or in the restaurant. You can do it right after you pump your gas. In flying, you have, number one, the airport, which is overall high traffic. You have high touch surfaces there that you can then touch and then spread it to your face by touching your face. And again, being in an enclosed flying cylinder for an hour or two or three certainly lends to higher risk as well. So absolutely, car is probably safer than flying.
Historically, there's pretty good documentation about how spreadable viruses are within airplanes, and that's documentation that we don't have for automobiles. So I think that feels a little safer to me.
Treatment question. Can patients receive blood thinners? If not, why? And a follow-up, what causes a stroke in COVID patients?
All right, let's start with what's causing the stroke, because that's going to turn us over to the question of blood thinners, Colleen.
Go ahead, Gary.
Dr. Gronzeth.
So what's causing the stroke is it's related to the inflammation. So there's always a link between inflammation and clotting, and that leads to clots in blood vessels, and if it's in the brain, you get a stroke. For COVID-19, there's a very strong link for not completely understood reasons between the inflammation and the clotting. And then additionally, in COVID-19, particularly in some patients, there's a lot more inflammation than we see in typical viral infections. So it's a setup just to do that. Now, you know, it kind of makes sense to think about blood thinners in patients like that, although there are not a lot of studies. There are academic centers, many stroke centers are, and COVID patients, depending on blood tests like D-dimers, are putting patients on blood thinners. Certainly, virtually all strokes that we see, whether it's related to COVID-19 or not, are placed on some sort of blood thinner, although that may be something like aspirin versus, you know, the stronger blood thinners like warfarin and the newer agents.
So, you know, it's interesting because what we know the blood is stickier, the vessels are stickier, you get a lot of clotting in your brain, but you can also get it in your kidneys, in your heart, in your lungs, in your liver, and hence multi-system organ failure that can go with COVID-19. Dana, you're in our therapeutics committee. What's the role of the more aggressive blood thinners like Lovenox for patients like this?
Yeah, certainly. You know, we know that the virus can cause direct pathological effects on the endothelial lining in the blood vessels, but also, as Dr. Gronseth talked about, the actual secondary inflammation as well. So we are using the higher dose and more therapeutic blood thinners, such as Lovenox. There are a couple other ones out there as well that we use typically in patients with stroke. That evaluation takes place as soon as a person gets into the hospital, and that continues through their stay as well, especially if they have critical illness and go to the ICU. They are put on blood thinners in an effort to protect against these consequences. Because we also understand, even if you don't have the large strokes, we also understand that there are microthrombi, or very small blood clots, that we haven't really picked up on in the past or with other diseases. We know those occur with this disease as well.
I think a lot of that disease, some of that information emerged out of New York from autopsy data where they began seeing these small strokes and like, wait a minute, and they saw it and they were seeing it in Italy as well, and kind of steered us into using more aggressively anticoagulation or blood thinners to try and help address those things. And as I remember, some of the data has shown a significant drop in ventilator days and in mortality in people who had that and got blood thinner versus those who had not when they went back and looked at some of the autopsy data.
Yeah, and if I could add, too, that we think that's probably a double hit as to another reason why people cannot oxygenate well or get oxygen to their blood well, especially in their lungs, when they are having these microthrombi, or these small blood clots, alongside the known inflammation that's taking place in the lining of the lungs as well. And so that's a double hit to people's breathing capacity.
Yeah, all the more reason that if you start having funny symptoms here, don't ignore those, right? Don't let fear cause a bad outcome for you. You know, fear. Don't let fear feed fear, because you could end up causing yourself some lifelong disability.
Is headache a sign of stroke, and does it have to be severe?
Colleen, what do you think?
You definitely can have headache with stroke. It's more common in the posterior circulation strokes, you know, the strokes affecting the back part of the brain, but it can happen in anterior circulation strokes. Usually isolated headache in and of itself is not stroke. Usually there are other neurological symptoms that go along with it.
What are some of the things you might see that go along with that, for the headache, and what else? Because you mentioned a particular part of the brain circulation.
Right.
Talk to us a little bit about how one side of the brain may manifest one way and another part of the brain differently.
Sure. So typically language is the left side of the brain. So you may see people having trouble talking, trouble understanding, weakness or numbness on the opposite side of the body that's affected of the brain. The posterior circulation strokes, people can have, these are a little trickier to pick up and oftentimes missed by the general public.
So posterior is in the back of the head.
Yeah, the back part of the brain.
Yep.
Back part of the brain, different part of the circulation than, you know, supplying the anterior circulation, but they can be tricky to pick up. Balance problems, double vision, vision changes, facial droop, also weakness and numbness, but it's not necessarily on one side of the body. It can affect both sides of the body. One key thing to remember is sudden onset is typically stroke.
Yeah, all those are important warning signs for going to get help.
And we have a be fast. You might want to talk
You
about
want
that.
to talk about that again? Because you'd mentioned it
Sure.
before, and let's hit it again. And I think
It's
we have
a good way to
graphic to go
remember.
along
Yeah,
with that.
definitely. So it used to be just fast, but we have added B to it because that addresses some posterior circulation strokes. The B is balance, so people who have trouble walking or even trouble sitting up. E is eyes, people who have loss of vision or double vision. The FAST is F, face, for facial droop. A, arms. If you ask somebody to put their arms up and does one of them drift down. And then S, speech. Do they have trouble talking or do they have slurred speech? And then T is time, just emphasizing the importance of coming to the hospital as quickly as possible and calling 911.
Is there a time in which it's too late? You waited too long to get to the hospital?
Yes, you may not be eligible, and that's probably the biggest reason that people are not eligible for kind of the acute treatment to try and reverse symptoms, is waiting too long to come to the hospital. But it's never too late to have medical care and have your risk factor assessment and try and make changes based off of your risk factors.
Okay, well, that's really good information. We have to remember, for everybody who's listening out there, be fast and around with COVID. Don't be slow, and don't be reluctant, and don't be scared.
All right, need clarification around anti-inflammatory therapies used for COVID. So do I need to be taking aspirin? Should I be taking ibuprofen?
So Dana, let's talk a little bit about some of those things for stroke, et cetera. We've heard a lot about, or initially, don't be careful with ibuprofen or with Motrin. And now I think that's kind of gone by the wayside a bit.
Yeah, absolutely. We understand that if people are at home, they'll have fever. It's certainly okay to take Tylenol or ibuprofen as it's directed. We understand also that ibuprofen, whether you have COVID or whether you don't, if you take it too much, it can have harmful effects. Certainly that is much more true if you're in the hospital and ill, or if you're critically ill in the hospital in the ICU. Mostly those effects have to do with kidney failure or acute kidney injury. So we certainly recommend taking ibuprofen in short courses or only as directed. But certainly for the treatment of COVID, there is no overwhelming evidence to suggest that you can't take ibuprofen. 1 or 2 or 3 doses, if you need to get down your fever, is certainly okay to take.
Yeah, makes good sense. And you mentioned, Gary, a little while ago, the use of aspirin in stroke. Talk to us a little bit about that versus these blood thinners. How do you know when to use one and when to use the other?
Well, this highlights the importance of coming in and getting the evaluation, because a big part of the evaluation is to figure out why you had a stroke. So I'm talking now about non-COVID-19 related strokes, which are the majority of strokes that are occurring. And so it all depends on what caused it. And so if it's related to hardening of the arteries, like atherosclerosis of the large blood vessels, that's where we tend to use aspirin. If we find out that it's related to your heart from a condition called atrial fibrillation, that's when we would tend to use a stronger blood thinner. So it all depends on the cause.
Yeah, so and all important rules. So other questions?
Yes, I have a neighbor that rides her bike by herself outside with the mask on. Is that really needed or a good idea?
Mask on, Gary. Gary, gosh, sorry. Well, wait, I'll ask you about the mask on, mask off. Dana, mask on, mask off, bicycling.
Yeah, you can call me Gary. He's much smarter than most everybody. I think that people have an initial problem wearing masks in general in public, and that's okay. We need to get by that. We need to get through to the protection of other people by wearing the mask. If you can tolerate a mask, doing physical exercise such as walking, running, or riding your bike, that is certainly okay. If you are just alone or in people in your household and you're outside doing it, it's probably not needed. Again, we are really looking for people wearing masks when they are in confined spaces, when they cannot maintain 6 or 8 or 10 feet of distance apart from other people, such as going to a store. If you prefer to wear a mask for your well-being, if you are out in public, if you're out at the parks, if you're riding your bike or walking, that's certainly okay. So we wouldn't discourage it, but it's certainly not needed or mandatory in the same sense that other situations would be.
And so, Dana, some people have said that bicyclists, you should give them 30 feet instead of 6 feet because they're traveling and when they exhale, the aerosols go all these places. What do you think about that?
I don't know. I think being outside is somewhat protective in the fact that we have so much dispersion by just even if you can't feel a wind, there is some air currents going on. There is such dispersion, and the concentrations of these particles and these droplets and these microorganisms will disperse and decrease so quickly once it hits the outside air and environment, especially if there are some winds going on. I don't know that 30 feet is necessarily needed.
It's interesting because there's a lot, you can get really scared of all the literature out there that says, oh, viral particles hang in the air for years or at least hours or whatever. And that's sort of the cloud theory. It's out there, it's like a cloud, and you always have to be afraid of it. Yet that's not really how this disease spreads. As we've said before, coronavirus is not a supervillain. It doesn't have superpowers. It doesn't fly around. It doesn't jump tall buildings. It doesn't go through windows. It can't transport itself into your brain, although it can cause strokes. It can't do things that are superpowers. And I think sometimes we ascribe too much superpower to it. We know that the basics really work, that if you do the basics, you're much safer. I remember back when we were first looking at this internally, we had the opportunity to speak for some folks from Wuhan, China, who had been through a time when they didn't have good PPE for their healthcare providers, and they had a lot of healthcare providers getting sick. Then they did the basics: gowns, gloves, face masks, and all of a sudden, their healthcare providers quit getting sick. I think it's really important for us to remember that this virus is not a supervillain or a superhero. All you really need to do is the good basics of infection control, and you can keep yourself and your family and your loved ones safe.
What about participating in an organized run event like a 5K?
Oh, a 5K. Is it time to go back to do the running event? So Dana's shaking his head. He grimaced. Did you see that? He kind of grimaced a little bit. He shook his head, and now he's smiling. Okay, Dana, I'm saying no to the run to the 5K.
I would agree with the no, just because, again, you are in such proximity to other people. Now, I know when you're out on the course, you're probably going to be separated, but certainly congregating together in that amount of people and at the starting line at that time when you are so close to other people, I think that's very dangerous. There could be asymptomatic or pre-symptomatic spreaders close to you. There could be people who have symptoms close to you, and I think that's very dangerous. And this goes along the line I was trying to talk about yesterday, in the fact that, you know, the same with protesters and freedom of speech. We want you to be able to protest and have freedom of speech. But if you can do that in a methodical way, in a thoughtful way, if you can maintain 6, 8, 10 feet away from other people to do that, and doing it with a mask on, you know, there are ways to do that. There are ways to probably do a run, but you're not going to be able to wear a mask. You're going to be in such close proximity to other people, probably for a longer time as you're waiting for the different heats of the people to run. So I think it's very dangerous, and I would probably say right now to hold off and not do that.
Well, you know, it reminds me of some of the super spreader events we talk about. And I remember there were a couple days ago we had a question about choir practice. Are those safe to go back to? And that was one of the best examples we've had of a super spreader event, where one person in a 2-hour choir practice spread it to multiple people, Dana. And I don't remember the exact numbers. Do you remember because they're pretty impressive?
I thought there were 96 participants. I think maybe high 80s actually got infected. So it was a good proportion of the people that participated in that relatively, you know, short choir practice. I think it was like 2.5 hours that group was together. So absolutely.
You translate that into, okay, what am I going to do at an event where people are all pushed together? That's what you have to be careful of. That's a super spreader event.
Inflammation question. How long does vascular or other inflammation last during post-COVID, especially in the brain?
Well, this is a hard question because we know that it can go for a while, and we see people coming back with symptoms about that. Let's talk a little bit about that, and then I want to use that as a springboard to get into the Kawasaki-like illness we're seeing in young children. Which do you want to take on the first part? Colleen said yes. She said, that's it.
Could you repeat the question again?
Yeah, inflammation. How long does the vascular or other inflammation last?
I don't think anybody really knows how long the vascular inflammation lasts from COVID. I think that's something that we'll probably get more information as the months and year go on.
And Gary, you mentioned a while back, you talked a little bit about the inflammation. Talk to us a little bit about kids and this kind of Kawasaki-like illness that some of them have had from inflammation.
Right, so it's the closest thing that we've seen, and of course, Colleen and I are adult neurologists, so we don't see this, but our colleagues at Children's Mercy do. It's a toxic shock-like syndrome that you may have heard of, and it's kind of mysterious in terms of, you know, what the actual link is. It seems to be very specific children that suddenly will get this inflammatory storm. I understand that you're seeing that in the ICU You
are.
know, this big cytokine release.
It is a
And so I
cytokine
assume it's a
storm.
related phenomenon.
Yeah, and I think that's one of the few times you can look at this, because we initially said no steroids, and now we're saying, oh, wait a minute, there may be some times where we're going to give steroids in this disease. So,
Correlation or high risk for Hashimoto disease and Bell's palsy.
okay.
So Bell's palsy is common, and so I think it's too early to say that there is a causal relationship between COVID-19 and Bell's palsy. Now, Bell's palsy is caused by inflammation, and it's inflammation by a virus, we think, most likely a herpes simplex virus. No evidence that COVID-19 does it. It's not a rare condition, and so it wouldn't be surprising to see a patient with both. And I should take a step back and say, in young people with stroke that otherwise have no other symptoms, when we see that they're COVID-19 positive, we're not even sure in that setting that the two are related. Now, we think so because in patients that are sicker, we see this relationship between the endothelial stickiness and the inflammatory disease. But even in that, we don't have the studies to say 100% that that there's a causal link. We're strongly suspicious of that, but we're not. Bell's palsy, we're way far away for saying that that's related.
Yeah, so it's a funny thing is we see young people, we see COVID, and we see strokes. And it's funny because most young people don't have strokes. So when you see that, it makes you think, okay, they have to be related somehow. We're just not quite smart enough to know what that relation is.
Yeah, so and we do see, pre-COVID, we do see young people with strokes, and oftentimes we do an evaluation and we don't know what caused it. And so when we find something like COVID-19 that, you know, we automatically make the link, but it's important to sort of be cautious. I think it's, for theoretical reasons, I think that we're justified in assuming that they're related, but there's still some uncertainty
Yeah,
about
there's
it.
something there. We're not exactly sure of what it is. But it comes back to the same message, Colleen, that you've been giving.
Right.
Don't wait, be fast.
Right,
And
right.
that-
Be fast, and it doesn't matter how old you are. You should go to the hospital because, as Gary mentioned, we do see young people who have strokes. We actually here at KU have kind of a younger patient population than they do nationally with stroke patients. So we're used to seeing younger people with stroke, including children. So if you have sudden onset of neurological symptoms, you need to go to the emergency room.
And you know, it's a concern because we know that people do stay home right now because they're afraid. And I think talk a little bit about some of the things that your team have been doing to keep people safe, both in the ICU or just in general in your service.
Sure. So our team is a little bit vulnerable because we do stroke activation. So we respond to the emergency room to see people with suspected stroke. And you don't sometimes have a lot of information about if they've had recent travel or they had sick contacts. Maybe people come in, they've been found down, they're confused, they can't talk. So basically, we just kind of treat every single patient like they are COVID positive and wear full PPE when we respond in the emergency room.
Yeah.
And it's the same with transfer patients too. We have a lot of patients who transfer from outside hospitals. Same scenario. We don't have a lot of information about, what's been going on with them. So we treat kind of everybody the same and wear full PPE.
And when you say full PPE, tell people what that involves.
We wear goggles, face mask, gown, gloves.
So our super cool goggles we just had
That's
on a
right.
minute ago that made us look even better than
Yes.
we do initially. Yeah, we love that.
And I think it's important to emphasize that that's not only helping protect the people on the stroke team, but it helps protect the patient. So when you come to the hospital, any hospital, you're going to be surrounded by people that have become expert on PPE, protecting themselves and protecting you. So it is a very safe place to be.
Really, it's probably much safer than the grocery store, much safer than the park, much safer than just about any place. And I think that's true for really all hospitals. I mean, I would just say, if you don't be shy about going to the hospital to get help. Dana, do we think we've had any examples of spread from one of our staff to a patient, from a patient to a staff in either direction of COVID-19?
No, we've done some contact tracing of some patients who, were found to have COVID-19 after admission because there were some possible healthcare worker exposures. That contact tracing was negative. And as far as healthcare workers giving COVID-19 to patients, we have not seen any of that again. And now we are continuing to take extreme personal protective equipment precautions on everybody. Everybody is treated the same. It is a abundance of caution, and it's rightly so. The main goal is to have our patients protected and our healthcare workers protected.
So important. All right, time for one more question, I think.
Gosh, they're really pouring in. Quickly, did you want to follow up on the thyroid? Are they at higher risk?
Thyroid Hashimoto's is, Dana, I don't know if you know that question. Do you? All right, we'll have to get back to that.
Okay.
Look for us tomorrow. We'll come back with that answer.
All right. And family members, 2 of them tested positive yesterday for COVID. Should I be tested? What should I start doing?
Yeah, did 2 family members got tested for COVID? They have it. Should another family member get tested? Let's talk a little bit about what that means to a family when one person gets sick. How can you prevent it? And more than that, is there anything you can do now at this point, Dana?
Yeah, this is tough to say. You know, we understand household spread from close contacts is probably 10 to 20%, depending on which study you're looking at. So it does happen, and it's pretty frequent. I think the first thing to do is start to set up good self-isolation practices in the household. You know, be aware of symptoms. I think that you can certainly contact your healthcare provider to get tested now, but in the coming days, understand that test is only good for that day. We could stretch it out to 24, 48, possible 72 hours, but in the meantime, you're going to continue to watch for symptoms, and you are going to continue to practice good at-home self-isolation procedures.
So really, the truth is that if you've been in contact with somebody who's had COVID, you may not know for up to 7 and even 10 days or longer if you're going to develop the disease, and you may well be in the pre-symptomatic period. You may have already got it and not even know it. So the real message is that the folks who have COVID-19 in a household need to be kept separate. We know from the data in Wuhan that it's not a guarantee that just because somebody in your household has it, that you're going to have it. In fact, you can keep the odds at 10% or less if you have non-intimate contact, you try to keep people separated, and you keep things where you're not like sharing utensils or sharing countertops and things like that. So that really that's a lot harder to do in a more crowded household. And then you just have to do the best with hand washing. If you got a mask, wear it. Do those things and ask the people who have the COVID to make sure they keep a mask on anytime they're around the rest of the family or in part of the central dwelling. So it's a tough environment, but there are things you can do because not everybody gets it. It's not a guarantee, and there's really nothing more than you can do. But make sure you take good care of yourself. Don't drink a lot of alcohol. Get some sleep. My mom always told me eat chicken noodle soup. I tell that to my patients, and get a little exercise. One more question.
This is interesting. Will some people not ever get COVID? Or is it just a matter of time? We're all going to get it.
Let's think about that. Is it a guarantee that we're all going to get COVID, Dana? As I think the answer to that is no. We don't all have to get COVID.
No, certainly. I think we would hope that most people wouldn't. You know, as we move further into this, and number one, if a vaccine is available and it's safe and efficacious, we would want people to get the vaccine. Moving forward in the more near term, if you can do the things that we've continued to prescribe and harp on and hammer in to do, then you will reduce your risk of getting COVID. So there are ways to protect yourself and decrease that risk. And moving forward, hopefully there will be also ways in which we can fully prevent you from getting COVID-19. So yeah, I don't think it's inevitable that everybody gets it. Certainly we've talked about herd immunity. Again, for most things, we say you need 80 to 90% of the community to be immune, to have herd immunity. Some of those numbers have dropped to 60 or 70% for COVID-19, but we would hope that everybody doesn't get it. We don't. We would prefer nobody else gets it. So it's not inevitable that everybody gets it.
So as we wind up today, let me turn to our neurological experts and say, as we finish up, what kind of thoughts do you want to leave our listening audience with?
I think just reiterating, what Dana and you have been saying about social distancing, wearing a mask, good hand hygiene, and not avoiding the hospital if you're having some kind of medical condition, including stroke symptoms, and go seek care. It's a safe place.
Just highlight that the hospital is a very safe place to be. I feel safer here than in many other places.
Yeah, I do too. Dana?
The same thing, we are coming into Memorial Day weekend. People are want to get out, gather. There's no pools, so I don't know if the gatherings are going to take place at people's private residence. Hopefully you're not going to gather in more than 10. Hopefully you won't gather with people outside of your household. But we have continued to say, do things in a safe manner. We really are preparing for a surge in 7 to 10 to 14 days. But if we continue to do everything correctly and as prescribed as a community, we can stop that surge and we can continue to have hospital rooms open, ventilators, PPE, and really have people not get sick is the ultimate goal.
I think as we wind down, this is one of those moments where I get to tell my story. I love these end of the time because I get to tell stories and let them be real honest. So for a lot of years here, I was one of the ICU staff, and I had these 5 rules in the ICU. Save the patient. That was always the first rule. Do the right thing. Do no harm. Make the numbers look good, because that was really telling the story of how we're making sure everything's all tuned up. And we have one of the rules, which is that sometimes it just takes time. And what that really means is that the longer it took for somebody to get sick, the longer it can take for somebody to get better. Pretty true rule up in the ICU. As we look at COVID-19, we all want it to go away. We want it to be done. We want SARS-CoV-2 to exit stage right. We're coming up on Memorial Day weekend, which is the gateway to summer, right? That's the typical thing where we go out, we have a great time. We have a great family tradition. Everybody would come over, we'd hang out at the house, people would jump and do whatever, and we'd fix barbecue on the back deck, and man, that was the best. And this Memorial Day is going to be different because we're not going to do that. And that kind of hurts my heart a little bit because it's a big deal to get everybody together. But what I really want to do is remember that there's going to be a lot more Memorial Days. And what you want to do is have good memories going forward. Sometimes it just takes time. You want to be safe. Don't rush it. Don't go out there and do things that we've been telling you not to do. Stay safe. Take care of your family. Take care of your loved ones. Take care of yourselves. And remember, sometimes it just takes time. We'll get there. It's coming. Vaccine, a lot of good optimism, a lot of great news this week around vaccination. There are things that are coming that are going to help us all stay safe, but it's going to take a little time to get there. So in the meantime, take care of yourselves, take care of your loved ones, and remember, there's still no place like home. We'll see you tomorrow.